Good evening, respected faculty and dear students. I am Dr. Chandni, Senior Resident in Department of Neuroanesthesiology and Critical Care at AIIMS Delhi. I would now welcome you all to the ISA National Classes, weekly classes being conducted for postgraduate students. This class is being telecasted live on the ISA NHK YouTube channel also. So before we begin the session, let us invoke the blessings of Ma Saraswati, the goddess of knowledge and wisdom, with our short Saraswati Vandana. Now, I take immense pleasure in introducing our esteemed secretary, Dr. Sukhvinder Bajwa sir, who has been playing an important role in conducting these classes every week. I would now invite sir to address the session.
Thank you, Chandni. Good evening, everyone. Today's class, I think, is more of a practical, theoretical, and clinical episode of what we are experiencing in our post-graduation. Because whenever we enter into our PG career, and right from the first year, in emergency, we always see such patients coming with a abdominal pathology where we head toward the resections and anastomosis or primary primary anastomosis or something like that, and later on by colonic conduits or even the ileal conduit. But these surgeries are not so simple. The anesthetic management, it seems very simple. Just giving GA for these type of patient is not sufficient enough. There are many hemodynamic fluctuations, disturbances. Plus, if this patient present with comorbidities, especially the most common among them is the diabetes mellitus also, then the challenges are always there for you to handle these during perioperative period. And as a postgraduate student, I think it's a learning phase for everyone. The more you learn about these surgeries, the more you become accomplished in handling such cases. So today we will be discussing all the details in minute way. And none other than the best teacher is Dr. Neela Malde. In our institution, I've myself seen personally, there are a lot of patients. I think there is no place for, to step inside the emergency also. So I think we should be now hearing a very, very good class today. And I hand over the stage back to Chandni and other moderators. So kindly start the class so we can hear it from Anila Malde Madam's team.
Thank you so much, sir. Now, I would like to introduce Dr. Pragnya Marna, who is also a coordinator of this session. Dr. Pragnya is working as a consultant at the Guru Nanak Hospital, Bidar, Karnataka. Now, I would like to request Dr. Pragnya to introduce the moderators for the session.
Thank you, Dr. Chandni. Good evening, all. I will be introducing the moderator for today's session. Firstly, I would like to introduce Dr. Anila Malde ma'am, who is a professor and head of the Department of Anesthesia at Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai. She is MD and DA, Guide for Maharashtra University of Health Sciences. She is faculty professor for postdoctoral fellowship course of anesthesiology at Lokmanya Tilak Municipal Medical College and General Hospital. She is also associate editor at IJ, past section editor, and she has 40 publications under her name and 21 text chapters and 45 CME chapters. She is also editor of the book A Practical Approach to Anesthesia for Emergency Surgery, editor for Pediatric Anesthesia and Comprehensive Clinical Anesthesia. Coming to the next moderator is Dr. Shalaka Nellore. She is an associate professor at Lokmanya Tilak Municipal Medical College. She is ex-executive committee member of ISA. She has pursued her diploma in hospital administration. She has 11 publications and 2 textbook chapters under her name. Over to you, Dr. Chandni.
Thank you, Dr. Pragya. Now I would like to welcome the moderators and to address the session.
Yeah. Good evening, everybody. Hi, I'm Dr. Anila over here. We have a student today, Dr. Priyanka Pathak, third-year student with our hospital and LTM Medical College. And she would be presenting a case of patient coming with for colonic resection, and patient is a diabetic one. So let's hear from Dr. Priyanka Pathak. Priyanka, can you share your screen?
Yes, ma'am.
And start presenting the case.
Good evening to one and all present here. The topic for my presentation is anesthesia management for diabetic patient posted for colorectal surgery. So the patient is a 49-year-old female who is an Anganwadi teacher by occupation. She came to our hospital with the chief complaints of multiple episodes of vomiting since 5 to 6 days, abdominal pain since 15 to 20 days, difficulty in passing stool since 1 to 2 months. History of presenting illness. Patient complains of difficulty in passing stool since 1 to 2 months, which is on and off in episodes. Straining was present. Last stool was passed 2 days back. There was sensation of incomplete voidance present. Flatulence was present, and there were black colored stools. She also complains of abdominal pain, which was since 15 to 20 days, which was insidious in onset, dull aching type, present in the lower part of the abdomen, present throughout the day. The patient said that it used to get aggravated on straining and relieved on passing stool or on consumption of laxatives. There was no radiation of pain to any other region. The patient also complains of vomiting since 5 to 6 days, which is non-projectile, non-bilious, multiple episodes containing of food particles. She had loss of appetite and weight loss present. There was no history of frank blood in stools or abdominal distension or hematemesis. There was no history of evening rise of temperature, cough, or cold. There was no history of urinary complaints. Past history. Patient is a known case of type 2 diabetes mellitus since past 8 years. She was diagnosed 8 years back when she had a primary complaint of blurring of vision in right eye, for which she had sought physician treatment and hence got diagnosed with type 2 diabetes mellitus and was started on treatment with tablet metformin 500 mg BD. During the initial 3 to 8 years of her life when she was diagnosed, she also had complaints of increased appetite, increased frequency of micturition, and her compliance to the oral anti-diabetic drugs was good, but she had poor compliance to the diet. 1 to 3 years ago, there was tingling and numbness present in the left foot associated with lethargy. So the patient again went to the physician, and the ADDs were hiked up to tablet glimepiride with metformin combination in the morning and tablet metformin 500 mg at night. The compliance to both diet and oral anti-diabetic drugs were improved. In the last 1 year, she had complaints of urinary tract infection, claudication pain was present in her left ankle. There was blurring of vision in bilateral eyes, right more than left, and also complaints of dyspepsia. Her oral anti-diabetic drugs were hiked up to tablet sitagliptin, glimepiride, and metformin combination in the morning, and tablet glimepiride and metformin combination at night. She was also started on tablet pantoprazole 40 mg before breakfast. And since last 1 year, patient has started to regularly check her glucometer at blood glucose at home. In the last 1 month, since her vomiting and constipation and abdominal pain, there was loss of appetite. Hence, patient had started developing spells of hypoglycemia and had started showing poor compliance to the intake of oral anti-diabetic drugs. There is no history of polyphagia, polyuria, polydipsia present. There was no history of hospitalization to either hyper or hypoglycemia. There was no history of joint stiffness, no history of ulcer over feet, no history of delayed wound healing, no history of steroid intake or recurrent infection. There was no history of syncope or giddiness on sudden change in posture. There was no history of gustatory sweating or early satiety. Patient is also a known case of hypertension since past 3 years on tablet telmisartan 40 mg OD with tablet amlodipine 5 mg OD. The dyspnea on exertion grade 1 was present. She had no history of chest pain, ischemic heart disease, CVA, or palpitation. There was no history of asthma, tuberculosis contact, COVID, jaundice, hyper or hypothyroidism, or snoring in the past. No history of past surgical history or ICU history. No history of blood transfusion. Family history. Patient's parents had no history of diabetes, hypertension, or cancer. Although her elder sister, who was aged 52 years, and her younger brother, who was aged 46 years, both were also diagnosed with type 2 diabetes mellitus. Obstetric history. Her parity index was para 6, living 5, death 1, all normal vaginal deliveries. Menopause since 4 to 5 years. There was no history of gestational diabetes mellitus during any of her pregnancies. Personal history. Patient belongs to a low middle class family. She has a non-vegetarian diet. She has a reduced appetite since past 1 to 2 months. There are nil addictions. She has complaints of constipation, but there are no urinary complaints at present. Her sleep is disturbed due to pain. My provisional diagnosis is a 49-year-old female who is a known case of type 2 diabetes mellitus with retinopathy and peripheral vascular disease and hypertension is posted for excision of colorectal mass. General physical examination. Patient was examined in sitting position in broad daylight.
Priyanka?
Yes, ma'am.
Can you wait? Dr.
Yeah.
Shalaka,
Yes.
would you like to ask her because she has come up to provisional diagnosis?
Yes, ma'am.
So let's
Can you go
discuss out
to
at least basics. You can ask her
Yes,
basics.
yes. So, Dr. Priyanka, basically, what you have found out from the history is that she is definitely a not very well controlled diabetic patient, right? And she has
Yes, ma'am.
had some complications as well. So, can you explain the basic pathophysiology of diabetes and what exactly leads to these organ damage, end organ damage, which she has presented with?
Ma'am, so the basic pathophysiology behind type 2 diabetes mellitus is insulin deficiency, insulin resistance, and glucagon excess, which leads into a state of decreased glucose uptake by peripheral tissues, increased lipolysis, and protein breakdown. The decreased glucose uptake by the cells leads to a state of hyperglycemia. It also leads to glycosuria, dehydration in the patient, and electrolyte imbalance. Due to breakdown of proteins, there is increase in plasma amino acids, and because of breakdown of lipids, there is increase in free fatty acids. All free fatty acid, ketogenesis, all this will lead to acidosis eventually, if not controlled.
Ketosis is mainly seen in type 1 diabetes mellitus. In type 2 also, some patients may present with that also because initially the insulin is adequate, but the resistance is there. So pickup is, the uptake of glucose is affected. But some patients may progress to like very little levels of insulin, but they are enough to inhibit ketosis. Okay, how would you classify diabetes now based on the pathophysiology?
So, ma'am, classification as per the recent American Diabetic Association is first is type 1 diabetes mellitus, wherein there is complete deficiency of insulin hormones. Second is type 2 diabetes mellitus, wherein there is the reduced production of insulin as well as decreased as well as insulin resistance. Third is gestational diabetes mellitus, and fourth are others. In others, we have pancreatitis, maturity onset diabetes mellitus, cystic fibrosis, other reasons because other endocrinopathies because of which leading to hyperglycemic states.
So, is it important to know what type of diabetes it is? Like from the history,
Yes,
you have tried to gauge that this is type 2. So, is it
yes, ma'am.
important, and how have you come to that conclusion that this is type 2 and nothing else?
Yes, ma'am. Ma'am, it is important to know because when we come across a patient in an emergency setting, if it's a type 1 patient, the onset of the hyperglycemic states and the symptoms would be at a much younger age. So they are completely dependent on insulin for their glucose control. Whereas in type 2 diabetes mellitus, they develop at a later on stage of life, and their dependency is not that much on insulin because it's an insulin resistant stage. So they are generally on oral anti-diabetic drugs. So if we have a patient with hyperglycemia, if we know it's a type 1 diabetic patient, we'll start on insulin rather than on oral anti-diabetic drugs.
And basal insulin also needs to be started in
Yes,
type 1.
basal insulin in type
That
1.
is
Yes, ma'am.
important.
Yes,
And
ma'am.
also, type 1 is associated with other autoimmune disorders.
Hmm,
So,
hmm. We have
what
to
history
rule
would
out.
you take for that? Because that is also important. If it is type 1, you need to rule
Yes,
out the
ma'am.
presence of other autoimmune
Yes, ma'am.
disorders.
Yes, ma'am. The other autoimmune disorders associated with type 1 diabetes mellitus are Graves' disease, Hashimoto thyroiditis, pernicious anemia, then etc.
Addison's disease and all.
Addison's disease.
Okay. And also type 2, have you heard of metabolic syndrome? So when you
Yes,
know
ma'am.
that this patient is type 2, you will also look at the other systemic involvement, which would
Yes, ma'am.
comprise
Yes, ma'am.
metabolic syndrome.
Yes, ma'am.
So can you
So,
tell
ma'am,
me
there are
how?
criteria. Yes, ma'am. So, to diagnose metabolic syndrome, as per the recent ADA guidelines, there are 5 criteria. If 3 amongst these 5 criteria are fulfilled, the patient can be labeled as suffering from metabolic syndrome or syndrome X. First is impaired fasting glucose, that is blood glucose of more than 110 to 125. Second is if there is obesity, wherein the waist circumference is more than 40 in male and 35 in female. Third is hypertriglyceridemia of more than 150. Fourth is reduced serum HDL cholesterol levels of less than 40 mg per dl. Fifth is hypertension of more than 130 by 85 mmHg. So if any 3 of the criteria are fulfilled, so the patient is at a high risk of metabolic syndrome.
High risk of atherosclerosis and more cardiovascular problems syndrome.
Yes,
Okay.
ma'am.
So how can you diagnose diabetes? Means what are the criteria for diagnosing diabetes? And because you said she was diabetic, so what are the criteria and what glucose monitoring she has undergone? So what do you think is the level to define somebody as a diagnosed as a diabetic patient or a pre-diabetic patient?
Oh, yes, ma'am. So, as per the recent ADA guidelines, for a patient to be diagnosed as diabetic, the fasting blood sugar level should be more than equal to 126 mg per dl. The postprandial blood sugar level should be more than equal to 200 mg per dl, and the HbA1c level should be more than 6.5%. Whereas in a patient who is pre-diabetic, her fasting blood sugar can range between 110 to 126. And HbA1c between 5.7 to 6.5%.
What is the role of HbA1c? Like in acute stages, is it going to help you in understanding if it is under control or not?
Yes, ma'am. So HbA1c is an independent predictor of worse perioperative outcomes. So when we when we have a patient in an emergency setting with a fasting blood sugar of 300, but if we have an HbA1c report, a recent HbA1c reports in the past 3 months, which is suggestive that the HbA1c is supposedly between 6.5 to 7 or 7.5. So it's still a better control. But if an HbA1c is more than 8 or 8.5, there would be other micro or macrovascular complications. If it's more than 8.5, the chances of retinopathy and nephropathy increases. So we need to be very careful during intraop phase to take care adequate measures like for the eyes, like padding of the eyes should be there. So HbA1c is an independent indicator to gauge the perioperative outcomes, worse perioperative outcomes.
So now you tell me what are
Okay,
the
Priyanka, I want to ask you
microvascular.
one question. Priyanka, is that every patient undergoing surgery, do you ask for the fasting blood glucose, or there are some specific patients whom you will be asking the fasting blood glucose levels?
Ma'am, so most of the patient we do check random blood sugars. We do not ask fasting blood sugars. Fasting, if the random blood sugar is deranged, like more than 200 mg per dl, then only we will consider asking for a fasting blood sugar with the postprandial blood sugar.
No,
Apart from that,
I don't agree with you, Priyanka, over there. Priyanka, it is basically whenever we want to check, whenever we want to look for diabetes, it's always better to do a fasting blood sugar rather than a random blood sugar. Okay, now this patient, obviously, there is a clear-cut history of diabetes. So you have asked for the blood sugar levels. Okay. But every individual coming for the surgery, do you ask for the blood sugar levels?
no, ma'am. We don't generally ask, but we should ask anyone aged more than 35 years or surgeries with infections like having a carbuncle or ulcer, non-healing ulcer. We should these infectious states should raise a high suspicion that maybe the patient has a high blood glucose count level.
So, Priyanka, I would like to add over here. See, there are very much guidelines available over for this particular aspect. Okay, all patients undergoing surgeries who are more than 45 years, we are asking for a fasting blood sugar. But those who are below 45 years of age, we do ask if one of the additional risk factor is there. Like, for example, if the patient is overweight, that is more than 25 kilogram per meter square, or if there is a family history of type 2 diabetes, or if there is a patient is leading a very much a sedentary lifestyle, okay, or in a female patient, if there was a history of gestational diabetes mellitus, or the previous baby who was born was more than 4 kg, or if there is a hypertension, or if there are cholesterol level, HDL is less than 35, or triglyceride is more than 250, or in the female patient, if there is a polycystic ovarian disease, or there is some history of vascular disease, all these patients, we should consider them as a risk factor for diabetes, and we should ask for the fasting blood glucose. Otherwise, in general, all the patients above 45 years, we do ask for the fasting blood glucose. So whenever if one blood sugar level is to be done, it is the fasting blood glucose which should be asked. Now you tell us about the examination finding of this patient.
Yes, ma'am. General physical examination. Patient was examined in sitting position in broad daylight. General condition: patient is conscious, cooperative, well oriented to time, place, and person. Her weight was 68 kg, height was 155 centimeter, with a BMI of 28.3 kg per meter square. Her effort tolerance was 2 flights of stairs with a MET equivalence of less than 3. Pallor was present. There was no evidence of icterus, clubbing, cyanosis, lymphadenopathy, and edema. Vitals. Her pulse was 98 beats per minute. The resting pulse rate was measured over 5 minutes in the right radial artery. The pulse was regular, good volume, normal character, normal conditions of vessel walls. All peripheral pulses were palpable. I had measured the BP in 3 positions: sitting, supine, and standing. With an appropriate BP cuff in the left arm. In the sitting position, her BP was 140/90. In the supine position, I made the patient lie down for approximately 5 minutes, and her BP was around 136/88. And then I made the patient to stand, and I measured the BP after 1 minute. Her BP was again 140/90. The saturation of the on room air was 98%. Respiratory rate is 18 breaths per minute, regular, abdominothoracic, no use of accessory muscles of respiration. Breath holding time is of 35 seconds. She was afebrile. Point of care testing blood sugar was 174 mg per dl. So I had also checked for heart rate variability in this patient. As you can see, at rest, on inspiration, her heart rate was 98 beats per minute, and on expiration, her heart rate had become 96 beats per minute. And with deep breathing, in after 1 minute, 2 minutes, 3 minutes, 4 minute, and 5 minute interval, we had checked the heart rate. Moreover, the heart rate variability is abnormal. Airway examination. Patient was examined in the sitting position. There is no visible craniofacial deformity. Both nares look normal. Mouth opening was 3-finger breadth. Modified Malampati grading was type 2. No buck teeth, no loose missing teeth or artificial dentures. Temporomandibular distance was 7 centimeter. Hyoid mental distance was 6.5 centimeters. Sternomental distance was 13 centimeter. Neck range of motion was adequate. No stiffness of neck present. Neck circumference was 38 centimeters at the level of thyroid cartilage. Upper lip bite test was grade 1. TM joint mobility was adequate on mouth opening. Prayer sign, this is the patient's prayer, the patient's hands demonstrating the prayer sign. It was normal. Palm print test was grade 0. We can see all the interphalangeal prints were present. Head to toe examination. No signs of non-healing ulcer were present on the feet. There was hyperpigmentation of feet was present as compared to the other parts of the leg. Abdominal examination. On inspection, all quadrants moved well with respiration. There was no dilated veins. Umbilicus appeared normal and inverted. On palpation, there was no rise in local temperature. Tenderness was present in the right iliac quadrant. Guarding and rigidity was absent. No palpable mass or organomegaly. Hernial orifices were normal. On percussion, tympanic note was present. No shifting, dullness, or fluid thrill. On auscultation, bowel sounds were present. Cardiovascular system examination. On inspection, her precordium appeared normal. Apical impulse was not visible. Carotid pulsations were not visible. There was no engorgement of superficial veins. On palpation, the apex beat was present in the fifth intercostal space, 1.2 centimeter medial to the left mid-clavicular line. There was no parasternal heave, no appreciable thrill or pulsation. Auscultation, S1 and S2 sounds were present. There was no murmur or added heart sounds. CNS examination. Patient was conscious, oriented to time, place, and person. Her head-to-toe examination was within normal limit. Cranial nerve examination was normal. Speech was normal. With respect to sensory, sensation to fine touch, crude touch, and pain prick was reduced in bilateral feet, left more than the right. Tone was normal. Power, bilateral upper limb was 5/5 and bilateral lower limb was also 5/5. Reflexes, bilateral upper limb and lower limb and deep tendon reflexes were normal. Spine examination, normal curvature of spine, no deformity present. Intervertebral spaces were felt on palpation. Respiratory system examination. On inspection, chest appears normal. Trachea appears to be in the center. Chest expansion is bilaterally symmetrical. No use of accessory muscles of respiration. No suprasternal or intercostal recession. Palpation, vocal resonance is equal. All findings of inspection are confirmed. Trachea is central in position. No tenderness or bony defect noted. On percussion, tactile vocal fremitus is normal. Resonant sounds present in the lung fields. On auscultation, bilateral air entry is present equally on both the sides and are clear. So my clinical diagnosis is a 49-year-old female patient with a known case of well-controlled hypertension grade 1 and an uncontrolled type 2 diabetes mellitus with diabetic retinopathy and early signs of autonomic neuropathy with colorectal cancer.
Shalaka, take over.
Sorry, madam, I can't hear you, madam.
Shalaka, would you like to ask questions?
Yes, madam. I was on mute. Okay. Priyanka, can you tell me, you have done so much testing, blood pressure in standing and supine. So what exactly were you evaluating and how do you go about, testing for autonomic dysfunction? Before that, you enumerate the macro and the microvascular complications and the end organ damage which is seen in diabetes.
Yes, ma'am. Ma'am, in diabetes mellitus, the microvascular complications are retinopathy, neuropathy, and nephropathy. And the macrovascular complications are coronary artery disease, cerebral vascular accidents, and peripheral vascular disease. Apart from that, there are autonomic dysfunctions, wherein there is orthostatic hypotension, gastroparesis, and apart from that, there is glycosylation of collagen leading to stiff joints or diabetic mellitus scleroderma. In the via the heart rate variability testing and BP in standing supine, I wanted to rule out any signs of diabetic autonomic neuropathy. So, ma'am, in diabetic autonomic neuropathy, in a CVS system, I would want the signs are generally resting tachycardia is present, and in my patient also, her baseline heart rate was 98 beats per minute. There is exercise intolerance. There is orthostatic hypotension, and these patients may end up with painless MI. With respect to the GI tract, these patients generally have gastroparesis, that is reduced.
Why did you check the heart rate in the inspiration, expiration? You recorded 2 full slides about all those heart rate
Yes,
in the inspiration, expiration. So what was the purpose of it?
Ma'am, respiratory sinus arrhythmia is a sign to test for parasympathetic system. In a normal patient, there is respiratory sinus arrhythmia, wherein on inspiration and expiration, there is a test known as deep breathing test to check it, wherein a patient is made to take deep breaths at 6 breaths per minute. And in that, if in a normal patient, the variability of heart rate should be more than 15 breaths per minute. In a patient suffering from diabetes mellitus with autonomic neuropathy, the heart rate variability reduces to 10 breaths per minute.
Why does
Less
that
than
happen?
10 breaths per minute. Ma'am, that is basically the parasympathetic nervous system is getting affected in diabetic patients.
So
Yeah, see, what happens is initially there is a parasympathetic denervation, then there is a sympathetic nervous denervation is there. So the first sign is the heart rate variability gets affected. So normally, even if we are having a normal breathing, then also heart rate is variable. Every minute it is not a constant. It would not remain 96 per minute every minute. So say 1 minute it could be 92, second minute it can go to 97, third minute it can be again 90. So heart rate variability is a normal thing. So first sign of the diabetic autonomic neuropathy is heart rate variability gets lost. Then there is a next sign is the resting tachycardia. Okay. After that resting tachycardia, because it is a parasympathetic denervation, so it is a sympathetic predominance. So resting tachycardia is there. Then slowly the patient starts getting effort intolerance because sympathetic denervation starts. Normally in response to exercise, obviously sympathetic gets stimulated. So that starts getting denervated. So there would be effort intolerance. And then finally, because the both are denervated, parasympathetic and as well as sympathetic, so you start getting the orthostatic hypotension. Okay, so that way the cardiac autonomic neuropathy progresses. Now, can you have some history which can also suggest that there is a autonomic neuropathy, or you have to rely only on science? So what are the histories which can tell you that this patient may be suffering from autonomic neuropathy?
Ma'am, in history, if the patient complains of exercise intolerance, which is seen in cardiac autonomic neuropathy, wherein the patient might say that she has lethargy or her daily day-to-day functions have reduced. Like initially, she was able to walk for 30 minutes, but now she gets fatigued soon. Or if the patient says that while waking up from a lying down position, she feels giddiness, or she needs to sit immediately after standing suddenly. So these are signs that the patient might have. Which
the other symptoms are the patient complains that while getting up in the morning from lying down position, If the patient gets up from lying down position, immediately she starts feeling giddy. Okay, that is because of orthostatic hypotension. Then the pupillary constriction and dilatation. Okay, that is normally sympathetic parasympathetic function. In the night, when you are lying down, obviously your pupil should get dilated. But if that is not getting dilated, this patient suffer from night blindness. Okay. Plus, this people complain of nasal stuffiness. Yeah. Then because of gastroparesis, they suffer from vomiting, diarrhea. They feel very much full after the food. They feel
Meal.
early satiety. Plus the bladder. A lot of people go to the urologist and all that because the bladder goes in atony. Then the sexual function suffers. They have impotence. And finally, they have something called asymptomatic hypoglycemia. So they can say the history from the family will come that one day patient was found, lying sort of unconscious. When the blood sugar was tested, blood sugar was low. But the patient never felt, earlier that signs of symptoms of hunger. So patient never got that hunger, typical that feeling of hunger or headache or etc. So this patient can get a asymptomatic hypoglycemia. So these are the symptoms. And what are the signs apart from this cardiovascular signs which you already elaborated? Are there any other signs which can be evaluated at the bedside for the
Ma'am,
autonomic neuropathy?
Ma'am, heart rate variability with standing, Valsalva maneuver, or in deep breathing
Okay.
rules out for parasympathetic. And for sympathetic, we check the blood pressure in standing, in sustained hand grip, and in Valsalva maneuvers.
Yeah, so could you describe like how exactly you check that systolic diastolic blood pressure for finding out whether the patient is having autonomic neuropathy or no?
Yes, madam. Ma'am, if for examination of orthostatic hypotension, we'll make the patient lie down in a supine position and tell them to rest in that state for minimum of 5 minutes. Then we'll tell the patient to stand up suddenly, and and in the supine position, we'll check the blood pressure once, and then we'll make the patient to stand up, and within 3 minutes, we'll check the heart rate again, the blood pressure again. If there is a drop in systolic blood pressure of more than 20 or 30 mmHg and diastolic BP falls less than there is a decrease by 10 mmHg, so it is considered to be orthostatic hypotension.
No, you have made a little confusion over here. Normally, also, when we are from the supine, when we turn standing, and within a minute, if the blood pressure is taken, there is a decrease in the systolic blood pressure by 30 millimeters of mercury, and diastolic blood pressure reduces up by about 5 millimeters mercury. But if the blood pressure decreases, systolic blood pressure decreases more than 30, or diastolic blood pressure decreases more than 10 millimeters of mercury, we can label them as having a autonomic neuropathy. If the systolic blood pressure decreases, say, from 11 to 29, they are borderline. You are not very sure. Okay. So in those cases, you will go for that Valsalva maneuver. So in the laboratory, all the detailed Valsalva maneuver can be performed. Yeah. And if the Valsalva ratio is less than 1.2, we can label them as a autonomic neuropathy. Now tell me, why do you need to have so many testings? Why do you want to find out whether the patient is having autonomic neuropathy or no?
Ma'am, so if a patient is having autonomic neuropathy, they are more prone to having painless myocardial infarction. They would not respond to our drugs like atropine or propranolol whenever there is bradycardia. They would have hypoglycemic unawareness. That, as you said, that they would not, even in a regional anesthesia case wherein we think that if the patient is having hypoglycemia, he might say. But if they have autonomic neuropathy, they would not be aware of having a hypoglycemia. They would have a delayed gastric emptying. So we need to be careful because all of them are considered to be full stomach. So aspiration prophylaxis have to be taken regarding they can have profound hypotension after neuraxial blockade, and if we are giving regional blocks, we need to be sure about the peripheral autonomic neuropathy, because they have numbness in that area, so they would not feel the pain while giving the block.
That is regarding peripheral neuropathy. Okay, we were talking about autonomic neuropathy. Okay,
Yes,
you are very right. See, the most important thing is most of our general anesthetic drugs would cause hypotension during induction. Okay, and this patient will not tolerate because they will not have a corresponding compensatory vasoconstriction. Yeah. Then whenever you are giving drugs like fentanyl, becuronium, propofol, all three of them are causing bradycardia. Now, this patient, if they develop excessive bradycardia, they'll not respond to atropine. Similarly, for any reason, if they are getting tachycardia, it will not respond to beta blocker.
Yes, ma'am.
Okay, normally in a response to blood loss, all of us do vasoconstrict, okay, immediately. But this patient will not have a vasoconstriction.
Response to tachycardia.
Then one more important thing all of us have to remember is that when we have for any reason, when we suffer from either hypoxia or hypercarbia, our central nervous system, respiratory centers get stimulated, and we immediately start hyperventilating. Whereas this patient who are having autonomic neuropathy can have a problems. They will not respond. Their respiratory center will not respond like that in the form of hyperventilation. Okay. So because the control of breathing is also affected. So we have to be careful while we are using any respiratory depressant agent. And this patient can have an unexplained cardiac arrest. So all these are the reasons why we do need to have all the testing. Somebody in between asked after how many years they start getting autonomic neuropathy. What is it?
Ma'am, so autonomic neuropathy is a chronic after 15 years. I'm not sure, ma'am.
Yeah, usually after around 10 years or so, they do start getting this autonomic neuropathy changes. Okay. And all other microvascular changes also they start getting after, means it's a gradual development. We can't pinpoint out exactly how many years, but they do start getting about after 10 years or so. Okay. Now, what are the other systems involvement? You were
These
telling
patients
something about
also
kidney
have
and other things.
diabetic cardiomyopathy, right? So what can you, what precautions would you take then in that case?
Ma'am,
Under anesthesia, what precautions would you take? Because these patients are also known to have diabetic cardiomyopathy.
ma'am,
First, can you
restrictive fluid.
describe something about this thing, diabetic cardiomyopathy? Can you tell us something?
Yes, ma'am. Ma'am, so these patients suffering from type 2 diabetes mellitus, they have accelerated atherosclerosis, and which can lead to angina and coronary artery diseases. They have cardiomyopathy, that is, there is impaired LV diastolic dysfunction. The systolic function remains normal. So because of the filling defect in the diastolic phase, since the ventricles are not relaxing, the left atria keeps filling and there is back pressure, so they are more prone to develop pulmonary edema, and they have cardiac autonomic neuropathy also, wherein the parasympathetic and the sympathetic denervation, so they would not respond, as madam had said that if there is a acute blood loss, there won't be the first sign is rise in heart rate, so they would not have a rise in heart rate, so we would feel that the patient is maintaining stable hemodynamics in spite of having major blood loss. So these are all the things.
What is happening at the cellular level in the cardiac tissue? Why do they get all this consequences because of
Ma'am,
diabetes?
because it is a prothrombotic and a proatherogenic state with a pro-inflammatory state, leading to advanced end glycation products are increased. Because of that, the patient are more prone for coronary artery disease.
See, basically what happens, whenever there is a persistent hyperglycemia, there is something called abnormal signal transduction, because normally opening up of potassium channel is very, very important in the cardiac tissue. Okay. So, and then the coronary vessels also. So whenever there is a persistent hyperglycemia, there is a decrease in the potassium channel activation, normally in response to ischemia or in a response to anesthesia. There is a ischemic preconditioning or anesthetic preconditioning. I'm sure all of the students must have heard sometime that all our inhalational agents and all, they cause anesthetic preconditioning. And there is a ischemic preconditioning also before the CABG. Before they do start clamping and suturing the vessels, they do a trial clamping of the coronary vessels, okay, to find out about ischemic preconditioning. So this ischemic preconditioning, anesthetic induced preconditioning, all are getting affected. Okay. Normally, in response to ischemia, the coronary vessels will dilate. But here, the coronary microcirculation is affected. So in response to ischemia, it will not dilate. There is an endothelial dysfunction also. Plus, at a biochemical level also, there are increase in the reactive oxygen species. Plus, there are advanced glycosylated end products. There's decrease in the nitric oxide production. Okay, so this leads to, at a microcellular level, all the effects. So there'll be decrease in the flow in the existing coronary vessels. Plus, normally, in response to ischemia, there is a coronary, the other circulation gets open up and the collaterals gets developed. But in this diabetic patient, the collaterals also will not develop. Then there is a generalized narrowing of the vessels. And even if you give any vasodilator, they will not respond like a normal vessel. So there is decrease in the dilatation in the response to vasodilators. Now, this persistent hyperglycemia will also cause, all these advanced glycosylated end products, angiotensin 2, free fatty acids. As we said in the very beginning, there's a lot of free fatty acid production. All these will cause increase in the reactive oxygen species. So there'll be extracellular matrix remodeling, endothelial dysfunction, there'll be apoptosis, that means cellular death. And whenever that cellular death is there, it will be replaced by the fibrous tissue. So there'll be fibrosis. Now, whenever the fibrosis is there, obviously the ventricles are not going to relax easily. Means you are going to see the diastolic dysfunction in the echocardiogram. As well as there is a cardiovascular autonomic neuropathy. There is problem in the beta adrenergic signaling pathway. Plus, as we said some time back, there is a decrease in the ischemic and anesthetic induced preconditioning. So all this will lead to heart failure, and there will be risk of the perioperative major events. Now, having known this, that this is happening at the cellular level, what precaution we will have to take, because they are susceptible to this heart failure. So what precautions we will be taking?
Ma'am, the IV fluids in such patients, we would not do a goal-directed fluid therapy. We would instead prefer a restrictive fluid therapy. That is, we would give as much fluid that is required as much as is lost during the surgery. We would give fluids. We would not give fluids very quickly in a in boluses very quickly, because they have diastolic dysfunction. Secondly, our threshold to start inotropes would be lesser. Like, we would prefer to start inotropic support early in such patients with diabetic cardiomyopathy. And thirdly, we would be very careful while positioning of such patients, because they would respond to change in position, would be more preponderant.
Yeah, you are very right. So, acute change in the loading condition, both the side, means excessive preload as well as too much reduction in the preload. Both will be harmful because they don't have a compensatory changes. Okay. At the same time, when the ventricle has to pump the blood, it pumps the blood against the aortic blood pressure. So if there is a too much of hypertension, okay, because of say laryngoscopy, intubation, lighter plane of anesthesia, anything, that hypertension also will cause increase in the afterload and the ventricle will not be able to empty out properly. Plus, myocardial ischemia, these patients are going to be highly prone because we said that the coronaries cannot get vasodilated over here. There is a less of a coronary collateral development also. At the microcircular level also, they're very susceptible. They have an endothelial dysfunction and everything. So they are highly prone to myocardial ischemia. So we have to maintain the demand-supply balance very well. So we have to control the heart rate. You cannot allow tachycardia in these patients. We have to try and maintain the sinus rhythm. That becomes very, very important over here. Yeah. Okay. So have we done with the cardiac system?
Yes. Yes.
Shalaka, can we go to the other systems?
Yes. Yes. So, Priyanka, you tell me what effects would it have? She's having history for around 10-15 years. So, what other systems are affected? You've already said one macro angiopathies are done. Now, what about microangiopathy? She's even symptomatic with retinopathy. So,
Yes, ma'am.
what are the implications of retinopathy that you would see? In fact, she was detected also with retinopathy.
Yes, ma'am. Ma'am, so in retinopathy, we would be careful, like if there is a position wherein the patient has to be kept prone positioning, so we would preoperatively do a fundus examination and all. And in when we are giving the patient a prone position, we would be careful in eye padding of the patient. Apart from that, in starting oral anti-diabetic drugs like pioglitazone and all should be avoided in patients who already have developed retinopathies. In such patients with retinopathy, they also have cataract, so there would be blurring of vision, so they should be advised regarding operative needs for that. And generally retinopathies are developed when there is uncontrolled diabetes with an HbA1c of more than 8. The oral anti-diabetic control should be improved in such patients.
One important thing is
because
that
there is a
you
lot
should ask for
vascular development. Shalaka, just 1 minute.
Yes, yes.
Here, there is a lot of, in the retinopathy, what's happening is a lot of small vessels are developing. Okay. So now this patient, we have to be extremely careful for laryngoscopy and intubation. If there is a sudden rise in the blood pressure, those micro vessels can rupture and cause further damage to the retina. So the blood pressure control is very, very important. Acute changes in the blood pressure should be avoided. Yeah, continue.
Ma'am, also one more point I forgot to mention. Retinopathy is also an indicator that post-operatively the patient might have cognitive dysfunction because they have cerebral micro circulation is also affected if the patient has already developed retinopathy. So in patients post-extubation, they might not be well oriented if the patient has retinopathy preoperatively.
Okay. Yeah. Now, what effect would it have on the renal system?
Ma'am, so diabetic nephropathy, it's also a chronic condition wherein for a prolonged period of time, if the patient is having hyperglycemia with HbA1c of more than 8.5, then the eGFR reduces, the creatinine increases. The first sign of diabetic nephropathy is microalbuminuria. If a patient is diagnosed with diabetes mellitus, so they at times they are started with ACE inhibitors or ARB blockers just because to reduce the chances of the patient going into diabetic nephropathy in future. If a patient already has diabetic nephropathy, so we have to be very careful in the post-operative period. For analgesic management, we cannot give NSAIDs, or in the even contrast we cannot give in the perioperative period if the patient already has diabetic nephropathy. We'll be careful in the doses of metformin. We'll be careful in the doses of insulin. So we need to rule out diabetic nephropathy in a patient with HbA1c of more than 8.5 by checking the EGFR, microalbuminuria, creatinine.
So even microalbuminuria is there, and the other thing you should find out is the ratio of the albumin, urine albumin to creatinine ratio. That should be less than 30 milligrams per deciliter. If it is more, then it is suggestive of damage, further worsening damage to the renal system. Okay, now what about the airway? You said you did those signs testing, prayer sign and palm print sign. So what does it indicate?
Ma'am, prayer sign is basically done in patients with type 1 diabetes mellitus. There is glycosylation of the collagen in the joints. There is tissue glycosylation. So these patients are not able to, if both the palm, both the fingers, they cannot efface properly, and hence there is prayer sign. And palm print sign is, I tell the patient to press his palm on the paper.
So what does it
See,
indicate? Sorry to interrupt you. What does it indicate? We've already seen the picture. So,
ma'am, that there might be glycosylated collagen buildup, and they might have limited joint mobility. So there can be limited joint mobility at the TM joint or the atlantoaxial joint. So while intubating such patients, we might have difficulty in extension of the neck, or so there might
other
be
thing is
difficulty.
even positioning of the patient is also impacted because they have that
Yes, ma'am.
diabetic scleroderma. So there is a lot of wooden like non-pitting edema at the neck and the back. So that positioning and is also difficult. So it can all give rise to difficult airway. Now, how does it affect the peripheral nervous system? Because this patient also has symptoms of peripheral vascular disease. So what are the implications here?
So, ma'am, in the peripheral nervous system, the patient generally, like our patient, had complaints of numbness and tingling sensation. So they have a glove and stocking pattern of neuropathy. And they would complain that the footwear, while wearing the footwear, there is slippage of the footwear, and anesthesia implication for us, we have to document properly that there is presence of peripheral neuropathy, because if we are giving some regional anesthesia blockade, we should be careful that these people, while injecting regional block in regional blocks like sciaticofemoral nerve block or something, generally a patient might feel pain if we are in the perineurium of the nerve, but these patients, the pain tolerance, they might not feel the pain, and we can lead up to neuropraxia, or we can damage the nerve while giving blocks to such patients.
Another thing is that basically they have the blood supply to the nerves is also affected because of
The
microangiopathy.
vasa vasorum is vasoconstricted.
So
Yes,
correct. So you should not use adrenaline in the local anesthetic drugs that you're using because it can further cause neuropraxia. Another thing is they
yes,
have
ma'am.
decreased sensitivity to electrical stimuli also. So it's better to avoid PNS also and just use the USG
Yes,
guided
ma'am.
nerve blocks.
USG guided nerve blocks have to be
Yeah,
given. Yes, ma'am.
and they are also more sensitive to the local anesthetic drugs. So the dose also should be reduced. Otherwise, you can also, and they also have more chances of carpal tunnel syndrome. So if you're giving more volume of the drug, it can further lead to compromise of the nervous tissue.
Yes, ma'am.
And one more thing is, so documenting this is also important, and documenting fundus examination also in case of retinopathy is important, because if they have any post-operative visual loss or something, then that will not be impacted. Okay. Now, what about the impact on the respiratory system because of diabetes, and how it would affect our management?
Yes, ma'am. Ma'am, the respiratory drive, there's a depression in the respiratory drive. These patients are more prone to infections. They would have reduced hypoxic induced ventilatory drive. So whenever there would be hypoxia, as madam had said, that a normal patient would hyperventilate, they might not hyperventilate. So we should be very careful while giving opioids like fentanyl, which is also prone for respiratory depression. We should be careful with benzodiazepine like midazolam. They should be avoided in patients with diabetes because they also might lead to reduce the respiratory drive of the patient.
What are the other considerations for general anesthesia?
For general anesthesia, ma'am, as in like,
what are the other considerations? Like, we discussed so much in detail about diabetes and diabetes induced end organ damage. So having seen all that, having heard all that, what are the main considerations while giving general anesthesia? We already discussed considerations for regional.
ma'am, the main consideration with general anesthesia is, firstly, these patients would be always, even if they have an adequate NBM, we would consider them with full stomach, like aspiration prophylaxis have to be given. They have gastroparesis. So for them, metoclopramide has to be given in the preoperative period. They should be avoided with benzodiazepine like midazolam. For anxiolysis, midazolam should not be given. We should be prepared for difficult intubation in such patients because they can have restricted mobility. For these patients, because they might have infections, so the tidal volume should be kept 6 to 8 ml per kg, and low flow anesthesia is preferred. The duration of the surgery also.
Induction? Do you take any caution during induction?
Yes, ma'am. Ma'am, we would like to not cause during scopy. There should not be sudden rise in the blood pressure in such patients because.
But laryngoscopy is afterwards. Even your induction should be gradual. And please remember, they have autonomic neuropathy. So, sudden vasodilatation, they don't tolerate well. So, agent like etomidate, which is a cardiostable induction agent, can be preferred. Okay. And whatever induction agent you use have to be used very gradually, you have to give, so that there is no sudden hypotension. Then when you start your positive pressure breathing also, it should be, you have to be careful. Excessive tidal volume also will cause fall in blood pressure. Okay. So these patients may not tolerate that well. Yeah. What about inhalational agent? Can you use any of the inhalational agents?
No, ma'am. Ma'am, isoflurane in vitro studies, sevoflurane and isoflurane have documented that they lead to rise in the glucose. So desflurane is preferred, but these are just in vitro studies.
To the best of my knowledge, you can use any of the volatile agents, okay, because they have hardly any effect on the glucose homeostasis. Okay, whatever is the other coexisting condition, okay, or an end organ damage, that becomes more important over here. So you have to accordingly take caution, and both the side hemodynamic changes, rapid changes on both sides, hypotension as well as hypertension, both will not be tolerated. So you have to be gradual in everything. Okay.
What about the role of alpha 2 agonists? Dexmedetomidine, clonidine?
Yeah, ma'am. So Dexmed is preferred in such patients because we cannot give sedatives like midazolam. If we want to sedate the patient, Dexmed is better.
So actually, anxiolytics also help in reducing stress response. So you can give, unless of course we are following ERAS protocols and then it is not given. But otherwise, you can use anxiolytics, even alprazolam the night before, just to reduce the stress response which can happen. And even dexmedetomidine, clonidine will do the same thing. They will reduce that stress hyperglycemia. And inhalation has also been discussed.
So now this patient has come for the colonic resection. So what are going to be our major important perioperative concern?
Ma'am, perioperative concern for this patient, since she is an uncontrolled diabetes mellitus, we would like to control it. She is already on oral anti-diabetic agents, which is sitagliptin, metformin, and all combinations. So we would like to, if there is no good control and they want to operate the patient, we might have to switch her to insulin. She also has diabetic retinopathy. So as madam had said that we would like to do fundus examination in the pre-op time. She has autonomic.
Please don't discuss whatever we have already discussed, okay? Because we would be running short of time then. Okay. Yeah, continue.
And she has autonomic neuropathy, so we would like to document that. I would like to do these investigations in her. So the routine investigations are.
Wait, Priyanka. So the major concerns are going to be because patient is coming for the major colonic resection because of CA. Yeah. So since he is having an uncontrolled diabetic mellitus, the main thing is metabolic disturbance in the perioperative period, because if there is too much of hyperglycemia, that will cause glycosuria, dehydration, ketoacidosis. Okay. Plus, since it's an uncontrolled diabetes, she's already having a hypertension. So we are concerned about even cardiovascular event. Then infection, and since again the incision is going to be a bigger one, impaired wound healing. Okay, so these are going to be major concerns. So yeah, what are the investigations you would like to do in this patient?
Yes, ma'am. Ma'am, so in this patient, the routine and as per our routine of investigation, we'll be doing complete blood count. So here, since the patient has cancer and pallor was present, the hemoglobin is something that I would want to see, and the WBC count, because these patients are prone for infection. Liver function test to rule out, because the oral anti-diabetic drugs are metabolized, and our anesthesia drugs are also metabolized. So I would want to know the LFTs. I would want to know the renal function test, because the patient might also be suffering from diabetic nephropathy. The serum electrolyte levels, the potassium especially, the urine routine microscopy to rule out microalbuminuria, chest X-ray and ECG. ECG because also she has hypertension, so LVH may or may not be present. Special investigations for her comorbidities, I would want to check for fasting blood sugar and postprandial blood sugar along with HbA1c to see her control of the drug blood sugar. Fundoscopy to rule out retinopathy, and lipid profile test because these people are prone for atherosclerosis. Radiological investigation wise, since the patient has claudication pain in her left leg, I would want to do a Doppler of bilateral lower limb. I would want to do an ultrasound of the abdomen and pelvis because of the hypertension, and 2D echo also to see the ejection fraction of the patient, so that I don't overload the patient with fluids intraoperatively.
Okay. Are these patients more prone to hypoglycemia also, or what?
Yes, ma'am. Because we keep for a colonic resection patient, these patients are kept nil, like the solids are stopped 48 hours. In some times, bowel wash are given to such patients, and they are kept on liquid diets. So there is a in pre-op phase, already the blood sugar levels start reducing, and we are giving them insulin or oral diabetic anti-diabetic drugs, so they are more prone for hypoglycemia in the intra period. So we need to be careful. In the point of care, glucose testing should be done during before the induction of the patient case, and intraoperatively also every 2 hourly.
Is that only diabetic patients do get hyperglycemia intraoperatively, or any major surgery can get a hyperglycemia intraoperatively?
Ma'am, any major surgery will have will have surgical stress leading to hyperglycemia because of the imbalance between the counter-regulatory hormones, namely cortisol, catecholamines, growth hormone, and glucagon versus the insulin. So since there is a rise in all these 4 hormones, there would be insulin resistance. The glucose uptake via peripheral tissue would reduce, and hence there would be there would be TNF alpha would increase, interleukin 6 would increase. So any patient with undergoing major surgery, they might have hyperglycemia.
So suppose a patient is getting too much of hyperglycemia intraoperatively. How would you find out whether this patient was sort of having a diabetes and not diagnosed, or he's not having a diabetes?
Ma'am, I would like to check the HbA1c in such patient if available, if possible, because that is the only test that would tell me about the past 3 months if there is a glucose, if the HbA1c is deranged. So the patient was already a diabetic which got diagnosed intraoperatively, and
Very good.
if the Mhm.
Very good. One more thing we have to remember is that, if the patient is getting too much of glucose variability, like one day the blood sugar is 80 and the next day it is 150, third day it is 70, like that, if it too much of variability, then these patients are also at a more danger. Okay. Now, why do we need to control this blood sugar intraoperatively? If we don't control, what is going to happen?
Ma'am, the blood sugar levels, multiple studies have proven that intra blood sugar level, if not controlled, there would be poor post-operative wound healing. There would be adverse, the mortality rates are higher in such patients, and the surgical stress is also much worse in such patients, in whom the hyperglycemia intraoperatively.
Basically, metabolic disturbance would be there because of the too much of glucose will cause a lot of glycosuria, dehydration. You will have to again give a lot of fluid. Okay, so dehydration is one problem. Secondly, vascular thrombosis are going to be very common. Infection is going to be very common. Wound healing is going to be affected. So, because of all these reasons, we need to control that blood sugar. Now, if we need to control the blood sugar, what range would you like to keep intraoperatively?
Ma'am, intraoperatively, I would like to keep the blood sugar less than 180. But there are tight controls, like there are surgeries wherein I would need a tight control of glucose between 70 to 110, like surgeries, especially CABG surgeries or neurosurgeries, wherein they would not tolerate even a sugar range of 160, 180. So there I would want to keep a tight glucose control. But other surgeries, I can still have a liberal control of less than 180 mg per dl throughout the surgery.
See, what you are talking now is slightly now changed over a period of time. Initially, like tight control was suggested by Mondenberg about a decade and a half back. Okay, then the multiple studies were done, and what they found that even in a intensive care unit, plus even in a cardiac surgeries and all that also, when we do a tight control, when you try to keep the blood sugar between 70 to 110 or so, what happens is there are chances, there are episodes of hypoglycemia. And whenever there are episodes of hypoglycemia, not only does it cause neurological damage, but it also causes a lot of sympathetic stimulation. And that sympathetic stimulation will cause hypertension, tachycardia, increased myocardial contractility, increased peripheral vascular resistance. All this will lead to myocardial ischemia. So the incidence of cardiovascular event increases. So now majority of people, for majority of surgeries, have accepted that the sugar range somewhere around 140 to 150 would be ideal, but up to 180 it is quite acceptable. Okay, don't aim for too much tight control, because in a diabetic patient the sugar level of, say, when it goes to 70, in a normal patient it is not hypoglycemia, but in a diabetic patient it becomes a hypoglycemia, and hypoglycemia is also equally dangerous. So, and this has been done, there was a nice sugar study, then there was a Canadian journal had written one meta-analysis. So after that it's been decided that around 140 150 is the best one. Up to 180 we should aim at. And even a WHO safety checklist also says the sugar between, ideal sugar is should be between 108 to 180. Okay, so that should be ideal. Anywhere between 72 to 216 is acceptable. Yes, in a CABG and all, try to keep around 140 or so. I mean, try that it doesn't go above 140. Yeah.
Yes, ma'am.
Okay. So this patient, now she's for the elective surgery. Okay, you listed out all the drugs. Could you just repeat what all drugs patient is on, and how you are going to now preoperatively optimize the blood sugar level, and what would be your orders for this patient?
Yes, ma'am. Ma'am, so preoperatively, this patient was on sitagliptin, which is a DPP-4 inhibitor. A DPP-4 inhibitor can be
little bit more. What are the oral drugs available in short, and which drugs patient is on? But quickly.
Okay. Ma'am, so there are insulin secretagogues like sulfonylureas and meglinotides. Apart from that, there are drugs which increases the uptake of glucose uptake in the peripheral tissues, like the biguanides and the thiazolidine. Yeah. Then there are drugs which increases the incretin effect, like DPP-4 inhibitors, GLP-1 analog. Then there are drugs which the urinary glycosuria, like they increases the
sodium glucose
glycosuria, like the SGLT2 inhibitors.
Okay, so this patient is on which all drugs?
Sitagliptin, which is a DPP-4 inhibitor, glycoside, which is a sulfonylurea, and metformin, which is a biguanide. So amongst this, DPP-4 inhibitors can be taken preoperatively and intraoperatively. They are considered safe as per the recent ADA guidelines.
Intraoperatively, patient will be NBM. But on the surgery, yes, patient can take. Yeah.
Sulfonylureas also the patient can take in the preoperative period, but they are insulin secretagogues. Day before the surgery.
Given on the morning of surgery, because they cause hypoglycemia. They are not given in the morning of surgery.
On the morning of surgery, sulfonylureas are avoided because they are insulin secretagogues.
What about metformin?
Metformin is given as per the recent ADA guidelines. Initially, people used to avoid it because of the chance of lactic acidosis, but as per the recent 2023 ADA guideline, metformin can be given on the day prior to the surgery as well on the day of the surgery if she's skipping only one meal. But if she's skipping more than one meal, that is our patient is undergoing a major surgery, so she will not be given metformin on the morning of the surgery.
She can be given metformin on the morning of surgery if her creatinine is normal, her eGFR is more than 50 ml per meter square per 1.73 meter square per minute, and she is not going to get any contrast. Okay, so she can be given a metformin. Which are the drugs which should be withheld specifically?
Ma'am, SGLT2 inhibitors are withheld 2 days prior.
Withheld?
Because studies have shown that patients undergo euglycemic ketoacidosis when patients are on SGLT2 inhibitors, and these patients are also prone for urinary tract infection. So we do not want a source of infection.
Basically, what SGLT2 inhibitors they cause excretion of that extra glucose through urine. So this leads to glycosuria. This patient can develop dehydration, and dehydration can cause ketoacidosis. Okay. So these patients are usually recommended, different guidelines recommend different period, but they are recommended to be withheld for 2 to 3 days prior to surgery. Okay. Now, would you like, if the blood sugars are coming, say suppose fasting glucose has come 180 mg%, would you like to control this patient with the insulin?
180. Ma'am, it depends if on the urgency of the surgery. If we would want to 180.
See, this is a time sensitive procedure, correct? Colonic resection is a time sensitive procedure. It's not that urgent that you have to do within 6 to 24 hours, correct? So you can try and put this patient onto insulin, yeah? And then take up the patient for surgery.
Surgery.
Yeah. So now, which are the insulin preparations available in the market, and what are the perioperative concern with that?
Yes, ma'am. Ma'am, so there are three kinds of preparation. One are the rapid and short acting insulin, that is insulin aspart, lispro, and glulicin. Then there are intermediate acting like NPH, and then there are long acting like insulin glargine and detimir, and there is an ultra long acting like degludec. So the concern with insulin, giving insulin is the risk of hypoglycemia in the patient. So rapid acting insulin is generally avoided on the day of surgery, but according to the recent ADA guidelines, we can give long acting insulin at 80% the usual dose on the night before the surgery, and also if it's a minor procedure, we can give it on the day of the surgery, but the dose is reduced to 80% of the usual. So the basal regimen of the insulin is maintained.
Okay. Now coming back to this colonic resection. So this patient is, say, posted tomorrow morning. Okay. How would you go about one is giving anesthesia, and secondly about glycemic control? So what
Ma'am,
kind
if
of
the patient
therapy
is,
would you like to give?
ma'am, for her, I would want to give general anesthesia. Along with that, I would, for the pain, I would want to put an epidural first before starting general, so that my intraop requirement of opioids would reduce, and pain management post-operatively would be well controlled. I would not be needing to give NSAIDs, which might be deleterious for her. So I would, with the help of epidural, I can maintain a stable hemodynamics intraoperatively. So I would plan accordingly for epidural,
What are the
difficult
advantages of
intubation.
epidural?
So you are planning for a epidural for analgesia, and you are giving general anesthesia. Okay.
Yes, ma'am.
And as we discussed, you are planning to do induction with the etobidatate.
Etobidatate. Yes, ma'am.
So the muscle relaxant of your choice.
Ma'am, I would prefer atracurium in her because she might have impending nephropathy. So I would not want to give vecuronium. And
Whenever impending nephropathy, it wouldn't be giving us so much. Vecuronium will give you much more stability in the heart rate. Okay. Anyway, whichever choice, it's not bad. I mean, you can obviously titrate the things accordingly. And intubation response, definitely you will try to avoid. Now, imagine this patient, you have kept this thing. What will be your nil by mouth orders? In our institute, what are the nil by mouth orders for this colonic resection patient?
Ma'am, in our institute for colonic resection, they are kept nil per oral till 6 hours to 2 hours prior to surgery. They are given only clear liquid 6 hours. So 24 hours before, they would be stopped all solids, and only clear liquids are given in the last 24 hours. In amongst that also, the patient are told to stop clear liquids 4 to 6 hours, depending on the kind of procedure that they're going through.
So as per ERA's protocol, normally we do that carbohydrate preloading.
Yes,
Okay,
2
oral
hours prior.
carbohydrate preloading. So what about this patient? Would you like to do, or because she's a diabetic, you would like to avoid?
Ma'am, ideally, I would want to do a carbohydrate-rich drink for her. So, according to the ERA's protocol, 2 hours prior to surgery, we give them 100 grams of glucose in 800 ml water. So that helps in reducing the surgical stress, surgical stress-induced hyperglycemia, because the patient is not in, and starvation ketosis is also not present in such patient. So, ideally, we should give to our patient.
Carbohydrate loading is done even the night before. And what quantity you said is given the night before. And on the morning of the surgery, 2 hours prior, 50 grams what is given and 400.
50 grams. Okay. Okay.
And studies have found that although there is hyperglycemia because of carbohydrate loading, you can still cover up with insulin. The advantages of having carbohydrate loading is far better. Whatever you mentioned.
Yes.
Somebody had asked in the chat, the question had popped up, is it considered for major surgery also? Yes, ERA's protocol, enhanced recovery is considered. There are different protocols for gastrectomies, colonic resection. Everywhere the ERA's protocols are there available. Okay. Yeah. Now, coming to this patient, see, you kept for that accordingly, you gave that nil by mouth orders and everything. Morning when the blood sugar was done, now this blood sugar has come to 200 milligram per cent. How would you like to proceed further now?
Ma'am, I would want to start variable rate insulin infusion for the patient. So I'll be able to titrate the insulin according to I'll keep checking the point of care glucose. I'll keep checking the blood sugar every hour.
Why do you want to go for a variable rate intravenous insulin infusion program over here? Can you justify?
Ma'am, because it would be. Yes, ma'am. Ma'am, instead of subcutaneous, I would want to go for intravenous because the chances of my control over the blood glucose level would be better in a variable rate in IV infusion because of the half-life of insulin given IV is less. So I can titrate it according to the blood glucose levels. If the blood glucose levels have increased, so I'll titrate it more, and if it has reduced, so I can titrate it accordingly.
Priyanka, this patient is coming for the colonic resection, so it's a major surgery. The duration of surgery would be anywhere like 4 to 5 hours. Then the procedure has a lot of hemodynamic changes. There could be both fluid shifts, temperature shifts. Okay, and the patient is not going to go on a meal for next at least 48 hours.
Yes,
okay, so patient is going to skip more than one meal. So in this kind of major surgery, which is a longer duration surgery, as well as the patient is not going to go on a meal for the means patient is going to skip more than one meal postoperatively, and there are going to be hemodynamic and temperature shifts. There, the variable rate intravenous insulin infusion should be given. Okay, could you tell me how do you prepare that and what precautions you have to take?
Ma'am, for variable rate insulin infusion, we take 1 unit per ml. The syringe is prepared accordingly, 1 unit per ml insulin. So we can take like 50 units in 1 ml or 50 ml 50 units insulin and diluted with 49 ml of 0.9% NS. And once I start this insulin, I would like to titrate it, and I would like to check the point of care glucose testing every hourly once I've started my insulin, so that the patient doesn't undergo hypoglycemia.
How will you calculate the bolus dose and infusion?
So,
ma'am, for the bolus dose,
how much you will start off now?
Ma'am, for the bolus dose, it is the blood glucose, the blood sugar level that is present. Like as Madam said, it is 200 minus 100 upon the total daily dosing of the patient. So total daily dosing is generally 1800 upon patient's insulin. Patient's blood glucose is 200 minus 100 upon the insulin sensitivity factor. The insulin sensitivity factor is basically derived from 1800 upon the total daily dosing of insulin. If we do not know the total daily dosing of insulin for the patient, we can take 40 as a safe factor.
40 as an insulin sensitivity factor.
Insulin sensitivity factor for the patient.
Okay, and then you will continue with the infusion. So roughly how much you would give in this patient now? The baseline blood sugar has come 200.
I'll start it off at a rate of 3 units per ml. 3 ml per hour, sorry.
See,
I'll start the infusion at 3 ml per hour.
Now, it is a simple thing. 200 minus 100, so it is 100 divided by insulin sensitivity factor. Since this patient was not already on insulin, we are taking as a 40 as an insulin sensitivity factor. So 100 divided by 40. So 2.5 units of insulin, the bolus. And then the infusion we can give as a blood sugar minus 100 upon 100. Blood sugar upon 100. Okay, so in this patient, 2 units per hour we can give as an infusion.
Yes,
And
ma'am.
then every hourly we will be checking. What are the precautions you will be taking simultaneously?
Simultaneously. Ma'am, when
This variable rate intravenous insulin infusion has to go through a
for
dedicated
specific
line.
IV
Okay? So
line,
there
yes,
has to
ma'am.
be a
So that
separate line. You will not be
yes, ma'am.
giving your ionotrope, or you are not going to give your antibiotics, other
Yes, ma'am.
sedatives, etc. to the same line. Okay?
Yes, ma'am.
And it has to be piggybacked with what? You need to give simultaneously some amount of glucose, correct?
Yes, ma'am. Glucose. Yes, ma'am.
Yeah. So it has
Yeah.
to be piggybacked with IV fluid, that is glucose with 0.545%, that is half strength saline plus
Saline.
KCl. Okay. At
GI.
a rate of about, in this patient, it will come about 60 ml per hour. Okay. Considering her as a 60 kg, it will be coming 60 ml per hour. You should be continuing that piggybacked glucose with half strength saline with KCl simultaneously with that insulin. When you are going to stop that BR-III, then only you are going to stop that glucose with insulin. So there should not be sudden hypoglycemia in the patient. Okay. And no other
Yes, ma'am.
antibiotics, other drugs should be injected through the same line. It has to
Same
be
IV line.
dedicated line only for that. Now,
Yes,
since
ma'am.
this patient is a colonic resection, what about the remaining fluid? What kind of remaining fluid you will be giving to the patient?
Ma'am, balanced salt solutions can be given to the patient.
Okay.
Like
Ringal
ringalactate can be given.
Yeah, you can give ringalactate. Now, when the surgery gets over, now this patient is shifted. Would you shift to the general ward, or you will shift to the high dependency unit or ICU?
Ma'am, I would like to shift this patient to high dependency unit because I would
Very
like
good.
to monitor her blood sugar.
Okay. So how long you will continue this insulin infusion for this patient?
Ma'am, as per we'll keep checking her blood glucose levels. We'll continue till the time her blood glucose doesn't come level doesn't come to normal. The insulin should be continued.
Okay. And what about the remaining fluids? This was a major surgery. Patient is not going to go on a food, correct? So what would you give the remaining fluids for the maintenance of the patient in the post-operative period? Hello, can you hear me?
Dr.
Am I
Priyanka?
audible?
Yes, madam.
Yeah.
Priyanka's
So we will
net.
continue IV fluids till the patient is taking a sufficient oral intake, correct? So till that time, we need to continue with the insulin infusion, okay? And how do we switch back to the oral thing then? This patient, because patient has undergone a stressful surgery of colonic resection, and it was an uncontrolled diabetes. So it is better that in the post-operative period also, we continue with the intravenous insulin infusion, and then we see the daily requirement. So at least for 48 hours, patient will not be on the orals. So those 2 days, we will see what is the 24 hours requirement of the insulin in the patient. Okay. And then when
Yes,
the
ma'am.
patient goes on the meal, at that time, we will switch to subcutaneous insulin for that patient. Okay. So suppose now today, if the surgery is done, today is a Monday. This patient will go on a Thursday. Patient is going to take a meal in the morning. So that till Thursday morning, our insulin infusion will continue. The dosing will be adjusted as per the blood sugar levels. And then we will see, suppose tomorrow's whole day, that is a Tuesday and Wednesday whole day, if the patient has say required about 20 units insulin over whole day, that means we will have to give this patient 10 units basal insulin at the night on the previous day. Say Thursday patient will be going on meal. So Wednesday we can give 10 units basal glargine, and then we can give
I think ma'am has lost connection, Dr. Shalaka.
Okay, so Madam was asking how we can convert variable rate insulin infusion therapy to subcutaneous infusion. So if the patient is in the ICU and has to be shifted to the ward from the PACU, he is recovering. So what we can do is we have to calculate the patient's requirement of insulin in the last 8 hours. So whatever is the amount, say if it is 10 units that he has taken, so 70% of that would be given as a subcutaneous dose, and that would be his basal insulin requirement. 70% of that last 8 hours of his insulin requirement. Remaining 30% would be given as prandial if the patient is taking orals. If the patient is not started on orals, then we'll have to
I'm
curtail
not
that
able
and
to
give
get
only.
Shalaka's voice clearly. Is everybody else
Sorry, madam.
getting?
Yes, ma'am. I'm able to hear,
So, madam,
madam.
yes, I was just talking about how it can be converted variable rate to subcutaneous regimen. And so if the patient is not taking orals, then it will just be basal and just the correctional dose which we give. Correctional dose is given if the insulin levels are, sugar levels are more than 180 milligrams per deciliter. Now, what care we need to definitely take is that when we are switching from IV to subcutaneous, because, and especially if the patient is type 1 or ketotic type of type 2 diabetes mellitus, he is prone to going into ketosis, even if there is little bit of stoppage of basal insulin. So when we give, when we are shifting from subcutaneous to IV, from IV to subcutaneous, we should ensure that there is no time lag between the two. So ensure that subcutaneous is administered at least 2 hours before stopping the variable rate insulin infusion, so that by the time variable rate IV infusion insulin stops acting, because IV insulin has a very short half-life of 5 minutes. So that effect will wear off and this would have already taken over. The subcutaneous dose would have already taken over. So that is how we can switch over. So madam, if you would like, you can take over now from here.
Yeah, there was in between, I missed out, but there was one question in the chat. Somebody had asked that on the morning of surgery, if the blood sugar was 350, would you like to take the patient for surgery or no? Now, first thing in that case, if the sugar was 350, I would immediately send for the blood ketone levels and urine ketone levels and sugar. So if the blood ketones are more than 3 millimoles per liter, or if the urine ketones are more than or equal to 2 plus, then definitely patient will require management like a ketoacidosis, and we will have to defer for the surgery. Okay. Now, if the patient's blood ketones and the urinary ketones are not this thing, means if they are negative, then in that case you have to think, now this patient will have to just review the previous day's chart, whether there was a sudden surge in the blood sugar level because of extreme stress, or the persistent last few readings are very high. If the persistent few readings are high, then it is better to defer for the surgery, because this is not urgent kind of surgery. Though it's a cancer surgery, it can wait for some time. Okay. But if it is just because of excessive stress, patient has got one reading which is high, then we can give a larger bolus dose, start with the intravenous insulin infusion, see that the trend is towards reduction in the blood sugar levels. If there is a reduction in the blood sugar levels, then we can go ahead with the surgery. I hope that suffices. And suppose if this was not a major
Madam, you have muted yourself.
In that case, the one can manage with the subcutaneous insulin. So when we want to go for the subcutaneous insulin, usually we go for the surgery which are less than 4 hours in duration. The surgeries where much hemodynamic and temperature shifts are not expected, and like hemodynamic stability is there, and patient is not going to miss more than one meal. There we can manage with them with the subcutaneous insulin. And for subcutaneous insulin, like again, you see the preoperative sugar levels. If they are more than 216 milligram per cent, again check the blood ketones and urinary ketones. If the blood ketones are more than 3 millimoles per liter, then we differ the thing. But if ketones are negative, then depending on type 1 and type 2, we decide the insulin dose. And at type 1 point, this thing, 1 unit of insulin will reduce the blood sugar by 54 milligram per cent. Whereas a type 2, because they are insulin resistant, you require high dose. So you require 0.1 unit per kg of the insulin dose subcutaneously. And then we will keep checking the sugar levels, and accordingly, we will repeat the subcutaneous insulins. But it should not become more than, it should not become that you are giving more than like if it is like requiring repeat subcutaneous insulins in less than 2 hours, then we will have to switch over to VR triple I. Am I audible?
Yes,
Yes,
yes.
ma'am.
Yeah. So that was about the perioperative sugar management. Now, are there any questions from the audience? Let's look at the chat. Somebody has asked if HbA1c is high, 8.1, and blood sugar level is normal, how to proceed? Again, it will depend on the type of surgery. If it is obviously, if it is a pure elective surgery, then we can try and control the blood sugar levels. But here the blood sugar level is a normal one. If HbA1c is high, that means over a last few days, the patient's, I mean, over last 3 months, the patient's control is not good. So in that case, if it is a pure elective surgery, wait. Otherwise, time-sensitive surgeries and all, you will go ahead with the due precautions.
Maltodextrin is used for carbohydrate loading. So in our institute, we are not using maltodextrin. We are okay. But in many other institutes in India also, people are using maltodextrin. It comes as a sachet of 50 grams. So it is the previous night, 2 sachets are mixed with 800 ml of fluid and given to the patient. And on the morning of the surgery, 2 hours prior, 1 sachet is given in 400 ml as carbohydrate loading. And maltodextrin is known to actually clear the GI in 2 hours stomach. So anyways, after 2 hours, the patient will have an empty stomach.
Somebody has asked how often intraoperatively blood sugar monitoring. Intraoperatively blood sugar monitoring, if it is a this thing, if it is VR triple I, if we are using 1 hourly blood sugar monitoring will have to be done. Okay. And postoperatively again, it is not 1 hourly, but you can do definitely 2 hourly, but it depends on the blood sugar levels. If the blood sugars are approaching on the lower side, means one thing we have to remember, these patients are equally prone to hypoglycemia also. So there again, we suddenly don't stop VR triple I unless the sugar levels are really coming down less than 70 milligram percent and all. So we continue, but in those period, we'll have to do more frequently blood sugar levels. Especially if it is a type 1 diabetes, then it is always recommended in a major surgery post-operatively also to continue VR triple I. And then we can do the blood sugar 2 hourly. But if it is coming closer towards the normal, or it is coming less than little normal, then it is better that we don't stop completely via triple I, but we supplement with some amount of glucose and do little more frequently the blood sugar levels. Any other questions?
Dr. Chandni, do we have any other question?
Yes, sir. Like initially, one question was missed, sir. A question from Dr. Muthukumar. How many years of diabetes is likely to produce autonomic dysfunction at the earliest?
Approx 10 years or so.
Okay, ma'am. Yes, ma'am. And next question, ma'am. Can effective sugar control cause reversal of autonomic neuropathy changes?
Pardon?
Can
I
effective
didn't get your question.
Can effective sugar control cause reversal of autonomic neuropathy changes?
I think so, and it will at least slow down. It will prevent the further progress.
Yes, ma'am. Thank you, ma'am.
Ma'am,
The questions are done.
Anila ma'am,
Yeah.
whatever the damage actually this has caused, it's over a long generation, long time, and the damage is not reversible. Definitely the progress can be stopped, but whatever
Yeah.
damage has been caused because of the autonomic neuropathy, that will
Yeah.
be there only. It cannot be reversed.
Yeah, but at least it will be slowed down now.
It will be progress.
The
If the
sugars
progress will be stopped, if the effective control is there, then the aging will take over from there. Otherwise, the reversibility is ma'am, very, 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 very less in these type of cases.
Okay.
Autonomic function.
Okay. Thank you, sir, for enlightening that.
Dr. Madhuri also want to add to that.
Yeah. This case is basically, I think Madam has completely discussed the diabetic part of the case. This case is taken up for colorectal colonic resection, right? For malignancy.
Yeah.
So this question is for the student. Where is she? Is she online?
Yes, ma'am.
So, how will you, what are the factors which will affect the colonic blood flow like? Because this will be one of the goals of your anesthetic management. So, how will you maintain the colonic blood flow to get good results, post-operative outcomes?
Ma'am, to maintain good blood flow, adequate hydration would be needed.
Yes.
The oxygenation, the FiO2 levels have to be maintained.
That is the blood gases. Okay.
Yes, blood gas.
The volume status of the patient is very important. Will goal-directed fluid therapy help over here? It has been tried for colonic surgery. Many cases of colonic surgery, especially as a part of ERAS, it has been used, right? Goal-directed fluid therapy, it can be used. Okay.
Ma'am, but the recent ERAS protocol for colonic resection has shifted itself idea from goal-directed to restrictive fluid therapy, wherein as much there is blood loss.
Goal-directed doesn't mean that you're going to overload the patient, okay? So there are different schools of thoughts, and there are so many research studies going on. But goal-directed has been tried in colonic surgery. Okay. Then anything else? What about the intra-abdominal pressures? Then the intraluminal pressures? Then your anesthetic technique, will it affect the colonic blood flow? You said you will pass an epidural, no, for your case. General anesthesia with epidural. So what is the effect of general anesthetic agents on the colon and on the anastomosis which is made? You must have heard of it, no? What about this isoflurane, sevoflurane? Do they affect the bowel wall? And neostigmine is known to cause contractions of the anastomosis, right? So if you give GA, that problem is going to be there. And if you even isoflurane is said to preserve the reactive hyperemia of the colonic wall. So that's said to be beneficial. And as regards your regional block, since you are giving an epidural, that will be very beneficial to the patient because it is going to improve the colonic blood flow. Both spinal and epidural regional blocks, they improve the colonic blood flow, which is good. And one more school of thought is there that your patient has got a colorectal carcinoma, right? So these local anesthetics are said to reduce the metastasis, intraoperative metastasis. You must have heard of that. So again, that is very beneficial. And most important, yes, exactly, lignocaine. And your epidural is going to bring down the stress response like anything. So the benefits of bringing down the stress response useful not only as a diabetic patient, but also post-operatively, the patient will recover earlier and the chances of infection will be less, and the bowel anastomosis will take up better, and everything will be outcomes will be better, wound healing will be better, and they even say that the adhesions that will be formed post-op in the bowel will be less. So you have chosen a very good technique over there. Huh? That's what I wanted to add.
Thank you.
And one more thing is, could you have, just because it's a colorectal thing, can you risk stratify your patient preoperatively using any risk index?
Yes, ma'am. RCIC guideline can be followed here.
That is very good. In addition, I will give you a hint.
MACE
Yeah,
guideline.
that is there. That is there. But I will give you a hint because especially this is a colorectal surgery. Some index which utilizes both intraoperative and preoperative parameters. Have you heard of CR POSUM?
Yeah.
So you can do that. That is colorectal POSUM. So it has got some 12 pre-op parameters and some intraoperative parameters, which include the blood loss and the peritoneal soiling and the type of surgery, things like that. Okay. Just applied it. This is other than your diabetic part. Okay.
Yes, ma'am.
Okay. Thank you.
I must confess, Dr. Madhuri, that, we quite a bit overlooked about colonic resection. Basically, case was written as a colonic resection because we wanted to discuss more of a general anesthetic management and perioperative
yes,
glycemic
madam, yes,
management.
Yes,
yeah,
yes.
I think we will have to take a lot of points of colorectal carcinoma as not covered today,
you
obviously.
will have to take one more class then if you
One
have
more,
to cover
yes.
colorectal
No,
carcinoma.
actually,
Yeah,
well,
for
actually,
that we have to take one more.
Yeah.
it was a mix of everything, rather, because it's not easy to cover in one class. If you go with the colonic emphasis, you will go with so many of the scores, so many of the surgical points also you have to discuss. Then diabetes, then there are other comorbidities. So many things are there actually. So it's very difficult to cover in one class and difficult to answer everyone also, if you ask me honestly. There will be many questions. So I think the time is also running out. Chandni.
How fractional doses of insulin calculated during NBM period? So during the nil by mouth period also, again, whatever I said earlier about calculating about the bolus dose as well as the infusion dose. So we calculate accordingly during NBM period also and give. And then once you have started infusion, there are ready-made tables available in all standard textbooks and all articles. There are ready-made tables. So then depending on the next blood sugar level, we either hike up or we reduce. But roughly it is about blood sugar level by 100, that many units of insulin per hour is given. Hope that suffices. Then there is one more question under G and beta blocker therapy. What are the signs of hypoglycemia intraop? It's difficult to detect hypoglycemia when the patient is on beta blocker intraop because patient will not throw any hypertension, tachycardia and all. So best is to obviously monitor the blood sugar levels. Any other question? Or any comments from Dr. Bajwa or Madhuri Kodi, madam?
No, ma'am, actually everything is covered. That's what I told, because it's a very difficult to cover such a large topic in one small class. Even if you go to under the laparotomy, the patient may take sometimes 3-4 hours for the laparotomy only. So in covering in 1 hour about everything is very difficult. But still, I think you covered very well. And at least Priyanka Pathak, She looked so much now composed. After the beginning, she was not. Now she looks so composed after answering almost everything. That's a really nice. You have prepared her very well. So I think there are certain questions which I think quiz time is also there in the. I think we have got 3-4 minutes. 2 or 3 questions can be asked. Dr. Madhuri and Dr. Nishant, can you come out with those?
Yes, yes. Just show the MCQs.
Yes, ma'am.
Priyanka. So the first question, the adverse metabolic, this is for the audience. All of them are unmuted. The adverse metabolic consequences of insulin deficiency are all except increased glycogenolysis and gluconeogenesis, ketogenesis and metabolic acidemia, protein synthesis, dehydration, and lipolysis. Please put in your answers in the chat box. So the answer is
Correct. It's correct.
Somebody has said C. Protein
Correct.
synthesis is the right answer. Okay, good. We'll go on to the next question. Which oral antidiabetic drugs can cause hypoglycemia and weight gain? Biguanides, sulfonylurea, SGLT2 inhibitor, DDP4 inhibitors, and thiazolidinediones. So everywhere the answer is common. A. Biguanides. So the correct answer is sulfonylureas. So the audience got it wrong.
Biguanides are given for weight loss.
Also will cause hypoglycemia and weight gain.
Yeah.
So both will cause.
Obese patients are given
Yes.
biguanides because it causes weight loss.
Okay, so what is the right answer then? Is it A or B?
B.
B. Go to the next one, just last MCQ. Which oral antidiabetic drugs can be administered in patients with renal impairment? Metformin, glyburide, pioglitazone, and linagliptin. So the response is A from the audience. The correct answer is linagliptin.
That is DPP4 inhibitor.
Yes. So I think the audience got it wrong. Okay. That's okay, sir? Enough of the MCQs?
Yeah. I think enough of the questions are almost finished.
Okay.
So I want to have certain felicitation of our faculty and speaker also today. Just wait. I think I have to share the screen also.
I think it was a very difficult case, whatever ma'am discussed.
Yeah, it was a difficult.
Very difficult, long case, yeah.
Is my screen visible?
Yes, sir.
Yes, sir.
Yes.
Yeah.
Yes.
So, Anila Malde ma'am, it's really, we are very thankful to you. You prepared your team very well and you took out the precious time to hold this class, which will be very useful for all the PGs who will be appearing for the examination or even during the first and second year also. They can also watch this class online, this one on the YouTube also later on after this class is over. So we really are very thankful and we feel very privileged to honor you on this occasion. This is a small gesture.
How long it will be available, sir, on the YouTube?
YouTube, yeah. Ma'am, it will be available in 10 minutes after the class.
No. How long it will be available? I mean, how many days?
Permanently.
Okay. That's very nice.
Yeah, ma'am.
Okay, fine.
Yeah, ma'am. And Shalaka ma'am, thank you. You
Thank you,
also
sir.
did a hard work in preparing Priyanka. So it was a good class and you equally deserve this felicitation from our side, ISA national side.
Sir, I would also like to thank all the organizers and Maldi madam also for giving me this chance. Because of her only I'm able to, be a part of this.
Yeah, ma'am. And then Dr.
Thank you,
Priyanka.
Shalaka.
And Priyanka, for you, now you have a very composed now, so you have to appear in the final examination also in this manner. Finally,
Yes.
okay, good.
Thank you, sir.
And Chandni and Pragnya, both your certificates are here. You held the class very well, so you are the good coordinators. So equally, we are happy to felicitate you also.
Thank you so much, sir.
Thank you,
and
Chandni.
Thank you,
and
ma'am.
Thank you.
also big thank you to Dr. Madhuri and Dr. Nishant for coordinating the class event. So that's from the Felicitation side from ISN National. Now back to the coordinators to conclude the events also now, because it's 8:30 now.
Okay, sorry for exceeding the time.
No, it's okay,
But,
ma'am. The class was long. It was required. Those things are required. They have to answer everyone.
Diabetes is a long case.
And we'll come back one day with that colonic resection also.
Yeah, sure. Yeah, ma'am.
Okay, thank you, Madhuri madam, for your comments.
Yeah.
Nicely doing all that colonic
Yeah.
resection.
Yes, ma'am.
Yeah,
So,
thank you.
ma'am, we shall always end at 8:30, and that's the maximum time because the other
Okay.
commitments are also there. So we are ending this class now. So I thank
Okay.
everyone, and good night to everyone.
Thank
And
you.
we
Sir.
leave the
you.
class by saying long live
Thank you,
ISA.
ma'am.